So on behalf of the European Reference Network on Rare Hematological Disease, I'm very pleased to welcome all of you today. So as you know, this program is dedicated to thrombotic microangiopathies, and this is a comprehensive program made of cycle of webinars, which has been developed in collaboration with the French Reference Center for Thrombotic Microangiopathy, the CNR-MAT. And so this program consists of 2 blocks, chapters if you want. And the first one was made of 9 sessions and dedicated to TTP. Now we are going to pass to the second block. Today is the first session of the second block, so that is dedicated to the HUS, so hemolytic uremic syndrome. But before that, before passing to today's session, I need to share some technical information. So as you can see, this session is recorded. So if you feel not comfortable with it, please switch your camera off. This is because, as you know, we record our webinars, so you can find them after on our e-learning platform and YouTube channel, EuroBloodNet Edu. And also this program is accredited with 11 continuing medical educational points of the European Board of Accreditation in Hematology. So in order to get them, you need to participate almost to the whole program. And 2 things that are very important is to write properly your name and surname in the platform, so we can track your presence. And also at the end of the session, you are going to receive a survey, a very simple one. It's a satisfactory survey, and also this is needed to be answered in order to get the accreditation, because it's a way to track that you have followed the program. So coming back to today's sessions, so today's topic is Shigatoxin-associated HUS, and is led by an expert of the field, so Dr. Dossier Antoine, who is medical doctor and internal medicine department of the hospital APHP Bichat in Paris. And he specialized in internal medicine and clinical immunology with a particular focus on immunohematology, intensive care medicine, and infectious disease. And he's also member of several institutions, like the already named the National Reference Center of Thrombotic Microangiopathies. He's also in the scientific committee of the National Reference Center of Autoimmune Cytopenia and the National Reference Center for Castleman disease. So please, Dr. Dossier, the floor is to you. Thank you very much.
Well, thank you very much, Marangela. I'm very glad and very pleased, very honored to present you this afternoon this session on STEC-HUS, which be a little bit particular because the focus will be on STEC-HUS in adults, considering that I'm no pediatrician, but an adult doctor. I have no conflict of interest to declare. And that's the plan of this session. We'll first talk about pathophysiology, epidemiology, and clinical course of the disease, mostly in pediatric settings at that time. Review the main evidences about the treatments, and we'll present you the French experience of STEC-HUS in adults through the CNR-MAT. Well, let's start with this seminal report, which was released in 1983. Seminal reports by Carmali and his colleagues, who first linked infectious digestive disease with bloody diarrhea leading to the onset of HUS and severe HUS in 15 children, and he linked both the infectious disease and the HUS by identifying in 8 out of 15 cases the presence of a toxin in the stool, which was responsible for a non-reversible alteration of vero endothelial cells. These cells coming from the African green monkey kidneys. This toxin was later on identified to be very close from that of Shigella dysenteriae, and thus called Shigatoxin instead of verotoxin. And all the E. coli that are able to secrete and produce this Shigatoxin are labeled STEC for Shigatoxin secreting E. coli. They belong to a group responsible for enterohemorrhagic diseases, referred to as AHEC. And the most famous of those serotype is O157H7, but as we'll see it later, it's not the only one. Well, this is a foodborne disease, and the first step is to identify the source of contamination, and the source of contamination comes from the food, which is food coming from the farm, because the reservoir is the cattle mostly, the cattle, the sheep, the goats, and people get contaminated mostly by eating raw meat or not sufficiently pasteurized or unpasteurized products from the farm. This is the main route. Some of the routes are possible also, like intrafamilial contamination, also secondary cases. Once the E. coli is eaten, then it can induce an infection in the bowels, and the infection will lead to the onset of a diarrhea, a bloody diarrhea in half of cases, inducing an alteration, an injury of the epithelial barrier of the gut. In certain condition of stress, the E. coli will produce the toxin, which will be processed by transcytosis through the epithelial gut barrier into the bloodstream. Once in the bloodstream, the toxin will be vehicled through the body and the organism, linked to their receptor, which is called the globotriaosylceramide, expressed on polynuclear neutrophils, monocytes, red blood cells, platelets, and these vehicles will lead to the delivery of the toxin to the same receptor expressed this time on the endothelial cells. Another way is that red blood cells, monocytes, platelets, and even neutrophils can shed microvesicles containing the same Shigatoxin, which will fusion with the membrane cell of the target cells. Once the toxin is linked to its receptor on the endothelial cells, it will be internalized and induce major endothelial cells alterations, most of which results from a protein synthesis inhibition. The toxin, the A subunit of the toxin, is capable of cutting mRNA, and this is the main way of toxicity. But it also increases the von Willebrand factor release. It also induces the activation of the complement pathway. It also induces the expression of adhesion molecules. It also induces the production of pro-inflammatory cytokines. Altogether, this leads to a very strong inflammation around the vessels and to the production of thrombus. And this thrombus, in the context of arterial vessels, you know that it's responsible here for the TMA syndrome. When considering STEC HUS distribution and epidemiology, one must have in mind that there are very important differences between children and adults in terms of epidemiology of TMAs. In children, the TMAs are quite rare, but the vast majority of TMAs are secondary to STEC HUS. It's even called typical HUS. It's over 90% of all TMAs in children. And what is not typical is atypical HUS, mostly resulting from complement abnormalities in children. Thus, it's very homogeneous, very uniform clinical picture in children. It's the first cause of acute kidney injury, organic acute kidney injury under 3. The death rate is about 2%, unfortunately. And this condition is under survey. And in France, there is a very efficient national surveillance network that can provide good data and a good overview of the epidemiology, the clinical presentations, and enables also the setting up of clinical trials in children. It's a totally different story in adults, in which STEC HUS is really rare, and the vast majority of TMAs are dominated by other causes, and nothing or very little is known, in fact, about STEC HUS in adults, with a death rate reported to between 5 to 88%, and there is no dedicated surveillance network, at least in France. What do we know about the clinicals of this disease in children, where it's more reported? The children, once they've eaten the E. coli, will develop mostly, maybe not exactly 95%, but mostly diarrhea, which is bloody in 2/3 of cases, and 15% of patients will develop HUS. HUS will concern kidneys in the vast majority of cases, and severe kidney presentations with dialysis required in 2/3 of cases, and neurological complications, which are very, very problematic, are observed in 20% of cases in children, with a death rate, unfortunately, of 2%, 1 to 3% around. When you look a little later, 5 years later, after the onset of the STEC HUS, fortunately, 70% of children have full recovery, despite sometimes a very severe disease at onset. But 30% also have renal sequelae, and 4% have neurological sequelae. The recognition of the disease requires, as much as possible, the identification of the strain of the bacteria of the E. coli responsible for the STX secretion. This can be done on any biological sample. Routinely, it's done on stool analysis, and you know these swabs very well everywhere in the world now. But these are not for the nose this time, these are for rectal swabs. On stool culture, to identify particular strains of E. coli, this requires selective culture media, because otherwise we would culture any kind of E. coli. So this is a little bit complicated and not available everywhere. There is a lack of sensitivity, and if you don't look for it, look after STEC exactly, then you might don't find it. There is a lack of sensitivity. There are delayed results, but it's also the best way to have antibiograms of these STEC strains, and it's a good way to identify the serotypes. The PCR has been a revolution during the last 20 years. for this disease, and it's very sensitive, very fast results, and it's possible to do it not only on rectal swabs but also on any biological samples. And it enables to identify not only the serotype of the coli but also the presence of the genes of the toxin and even the subtype of the toxin, which can be sub STX1, 2A, 2B, and also virulence genes. When looking at the worldwide epidemiology of STEC HUS and STEC infection, immediately you can see that it has been reported in most developed countries, but not everywhere in the world, so there is a big hole immediately. And on these data, it is estimated that STEC infection induces illness in about 3 million persons a year and induces HUS in about 4,000 persons a year. But epidemiological data are limited by some technical aspects, which is the technique used for detection of STEC infection. Was it serology? It's now abandoned. Is it stool culture? Is it PCR? Which is the serotype looked after? Is it only O157, which has long been the only serotype looked after, or is it any other serotype? Is it surveillance network reporting also sporadic cases or only outbreaks? Well, of course, epidemiological data are really weak, in fact, in this condition at worldwide level. Here is a distribution of cases in a survey, in an active survey, which was performed in the United States during the 2000 years. It involves 8 centers, 45 million persons living in these areas. And the purpose was to actively survey the presence of 157 H7 infection. It's clear that it's mostly a pediatric disease. And the vast majority of cases occurring before the age of 10 or even 5 years old. And the adult cases are really rare. However, they are rare, but there is a slight increase over 60 years old. And this population is of real interest because they are more severe. Among the 10 people who died with HUS, 5 were in this group of 60 years and more old. In 2011, there was a huge outbreak in Europe that you probably know, all of you. And this huge outbreak was linked to particular strain O104H4 strain of E. coli, meaningly different from O157H7, which was until then the most important reported one. And this outbreak was really frightening because in 3 months from Germany to by spreading all over Europe, there was about 4,000 cases of E. coli infection responsible for 845 HUS. And a surprise was that 88% of the clinical infections and of the HUS concerned adult people. So it's not only, it's in sharp contrast with the previous slide, and it's not only a child disease, it's also an adult disease. It's an adult disease and severe disease with 54 people who died. This huge amount of patient has led to an enormous production of science and of research on and of literature. But considering that the strain was really an exceptional strain, it was belonging to the enteroaggregative group and not to enterohemorrhagic group, and it was very resistant to antibiotics, producing an extended spectrum beta-lactamosis. The extrapolation of these data to all adult cases of STEC HUS may be hazardous. Some data come from these from this outbreak, and some not. And unfortunately, despite the huge amount of patients, when talking about treatments, there are still more questions than answers, and no clear evidence for the use of any of these treatments. The only clear point is that supportive care and early saline infusion in case of STEC HUS is definitely a good point. It was shown here in a pediatric cohort again, that it could improve the renal prognosis, the short-term and long-term renal prognosis, and it was almost significant. It was also able to limit the CNS involvement. The second point is plasma exchanges, which is routinely performed in adults facing TMAs, and not routinely performed in children facing STEC HUS. In fact, the data were reviewed in this paper from Kinswick, and in pediatric studies, it even appears that plasma exchanges may do more harm than benefit. So they are not recommended in pediatric settings. On the other hand, in adult cases, and you have to remember that adult cases of STEC HUS are minority among the cases of TMA, it's still difficult not to perform plasma exchange facing a TMA in adults. Whether it's useful or not when the clinician is aware of the context of STEC HUS, it's not clear. And at the end of this review, the conclusion is that limited and weak current evidence suggests potential efficacy of early plasma exchange in reducing case fatality rates in elderly patients with STEC HUS. So weak evidence for severe patients, maybe more those with neurological involvement, but very weak evidence. Antibiotics is quite naturally evoked when thinking of an infectious disease, but unfortunately there is again conflicting evidence, with some evidence suggesting that antibiotics use in front of diarrhea induced by STEC may induce the onset of HUS. So this is not in favor of the use of antibiotics. However, some other data do not support the same observation, and this may be linked to the difference between the types of antibiotics used, and which is really important in this case, because bacteriolytic antibiotics and bacteriostatic antibiotics do not have the same effects in terms of toxin production. Here is the example of ciprofloxacin, which is a bacteriolytic antibiotics with a very efficient effect on the reduction of the CFU concentrations of E. coli, with antibiotics increasing concentration, very efficient. But despite that, it is linked with an increase in the concentration of the STX. So it helps and releases the STX in E. coli. In the other hand, On the other hand, azithromycin, which is a bacteriostatic antibiotic, as you can see here with the growing concentrations of antibiotics, the production of STX is limited and efficiently reduced with the increasing dosage of antibiotics. This is illustrated by this clinical trial, which was performed during this O104 outbreak in 2011, in which azithromycin for 3 days was shown to reduce the duration of E. coli carriage, and it was not associated with the induction of HUS. So there may be a place for antibiotics in preventing from HUS, maybe, if the antibiotics, if the right antibiotics are used, and especially azithromycin is a promising one. Complement blockade is a very complicated issue, I'd say, and very important issue. There are several evidence in vivo, in vitro, and animal models indicating, supporting, demonstrating the implication of complement pathway activation during STEC HUS. It's quite clearly demonstrated. This has led to proposing severe cases to use eculizumab. In 2011, Anne-Laure Lapérac and some colleagues did report the use of eculizumab in 3 children with very severe STEC HUS, including CNS involvement, who were refractory to plasma exchange, and they were treated with eculizumab. Under this treatment, there was an improvement of the status. This paper just arrived exactly at the same time than the outbreak in Europe. And based on these data, it has encouraged the wide use of eculizumab for the most severe cases during this outbreak. Unfortunately, considering the emergency context and the very complicated context, it has not been possible to build in such an emergency randomized controlled trial testing the efficacy of eculizumab. And all the data we have come from observational study and real life use. What we can see is that in real life, the less severe cases were only treated with best supportive care. And the most severe cases, here is in presence of neurological symptoms. Here is the presence of renal replacement therapy. The most severe cases were treated by TPE and eculizumab, and the same here. Unfortunately, from those data, we can't draw very strong conclusions, but when trying to match and adjust these discrepancies through a propensity score, in this study, there was no clear benefit of eculizumab added to plasma exchange versus plasma exchange alone. So we would be very glad to have the results of randomized controlled trial prospective, and 2 of them have been planned, one in France, one in the UK. In France, the study was called EculiCHU, and EculiCHU has included severe forms, has included children with STEC HUS, but severe forms were excluded. In particular, CNS forms were excluded. The trial is now finished. The data are not published, but the communication last year at the ESPN yielded negative results, unfortunately. EcuSTEC is the English study which was a little different in terms of recruitment, including patients of all severity, which means CNS included. And unfortunately, it was recently claimed that the sponsor interrupted the financement, and then the study is now stopped. It was just said a few days ago at the ESPN in Amsterdam. And for antibiotics, there is another one, which is Zitroshu, which has been performed in France. The inclusions are now completed. It concerns severe form, again, it concerns children with STEC HUS, but severe forms excluded, and the intervention consists of azithromycin versus placebo for 3 days. The results are not known yet. So what about the adults? The data, as you may have understood, are really limited in adults. Otherwise, only the main data source is this epidemic of 2011. And we thus tried to perform a large analysis of the French cohort of all, including all patients. It was a retrospective cohort analysis of all adult patients with TMAs documentation of STX infection by PCR in any sample. The patients had to be reported in the CNR-MAT cohort, covering all of our France, mainly adult clinicians and are implicated in this cohort. And they also could be referred to the CNR-MAT by the laboratory, the National Reference Center for Escherichia coli, Salmonella, Shigella, which is based in Institut Pasteur. Altogether, we identified 96 patients with available data, and I will present you the clinical picture of these patients. They are found all over the territory with the novel representation of Île-de-France region, which is enriched in population. It's 1/6 of the whole French population, so it's quite expected. There is a slight female predominance, like in all other outbreaks dealing with STEC, HUS, and a clear a peak of incidence around 60. In green, in terms of serotypes of the strain, in green you can see that the 104 cases, there were 8 adult cases in France, all occurring in Bordeaux. All did occur in 2011, and 104 is not found later on. In red, you can see that 157 cases are not the majority. They do occur, they still occur, but they do not represent the majority of cases. And the majority of cases is finally all the other serotypes with an increasing interest in O91, O80, O26. These serotypes are maybe a little more virulent, and O80, for instance, is from time has been reported to be responsible for bloodstream infections. So it's maybe a real subject of concern. Another point is that we can see that cases do occur all over the year, all over the time, and it's not only outbreaks. All the cases, except these 104 cases, were sporadic cases, and it's not outbreaks. And there is an ongoing circulation of STEC HUS. Who are these people, these patients? The median age is 60 years old. And 60 years old, yes. And what is striking is that they have really high proportion. There is a really high proportion of patients with at least one underlying condition. Condition expected at this age, cardiovascular disease, but also conditions a little more unexpected, such as gastrointestinal disorders, severe ones with gastrectomy, gastric cancer, complicated biliopancreatic disorders, cirrhosis, so important gastrointestinal comorbidity and underlying condition. And the second one is that more than 1/4 of the patients did present an immunodeficiency. So a little aged, 60-year-old with high prevalence of underlying condition, mainly immunodeficiency. And when you look closer to the kind of underlying conditions, many of them are also known to favor TMAs, such as autoimmune disorders. There were systemic sclerosis in these diseases, such as solid organ transplant or even more bone marrow transplant, hematologic disease, use of calcineurin inhibitors. Altogether, these coexisting TMA factors were found in 31% of cases. The patients do not present in the majority fever. The infectious signs are not that important. They have frequently high blood pressure. This is not exactly the picture of a severe enterobacteria-induced infection. Instead of having low blood pressure, they have high blood pressure. In all cases, as expected, in fact, they had kidney involvement, from time to time mild kidney involvement, but in the majority very severe, with 2/3 of the patients who required renal replacement therapy. Diarrhea was observed in 83% of cases, which is important, but not all the cases. And it's quite important to recognize that some patients did not have digestive symptoms. The diarrhea was bloody in half of cases, and the colitis was severe in 12% of cases, requiring surgery from time to time. The very important finding and unexpected finding is the very high proportion of patients presenting CNS involvement. Almost 3/4 of the patients did present CNS involvement, and half of the patients presented severe CNS involvement, including focal deficiency, coma, seizure, leading to very severe disease, requiring intensive care unit management, and 1/3 of the patients needed mechanical ventilation. So very, very severe disease with a high proportion of patients with CNS involvement. The microbiological findings are detailed here, and as expected, most documentations came from stools, but not only, and 10 patients had a STEC positive identification in either urine or blood samples. From time to time, multi-site, confirming that end stools and urine or end stools and blood samples could be involved. And this is also a surprise. We had the opportunity to analyze, not exactly that, complement alternative pathway abnormalities that had been looked after in 69 patients out of 96 in Hôpital Européen Georges Pompidou by Véronique Romobaki, and no significant complement alternative pathway abnormality. One should note that it was only for 14 patients there was genetic data, so it's not for the majority. 2 patients out of 72 who had a dosage of ADAMTS13 activity had also a low ADAMTS13 activity. They had both together, and an STX documentation and an authentic TTP defined by low ADAMTS13 activity and the presence of autoantibody anti-ADAMTS13. It's supposed, it is, we haven't understood these cases as STX being a trigger of TMA in the context of previously installed ADAMTS immunization. The main point is that it's extremely severe because in-hospital death was observed in almost 20% of cases. And when you look closely to these curves, you can see that the beginning is very steep, corresponding to the intensive care unit death linked to the TMA. And the second part is more gentle, corresponding to patients very weak who can't face the aggravation of their underlying conditions. So all the in-hospital deaths are not directly linked to the TMA. How have they been treated? 10 of them have had only supportive care. As expected in an adult population, the majority of them have had plasma exchanged at least at the beginning of the treatment. And some of them have had only eculizumab. Eculizumab could be added in 31 of cases treated with plasma exchange, and 3 of them even had immunoadsorption. There were bias into indication of this treatment. It's no controlled trial, it's just observational real-life study. And we tried to identify prognosis factor influencing overall survival. And after a univariate analysis, all these were identified as potentially significant. But after a multivariate analysis, the 2 main and only significant factors were the presence of immunodeficiency with a hazard ratio of death of 3.5, and the occurrence of a major neurological event with a hazard ratio of 3.4. At last, we tried to assess the effect of eculizumab on survival, and to get rid of the indication bias, we performed a propensity score matching, which led to the conclusion that eculizumab was not associated with survival in this study. It's weak evidence, but it's another one. So, in conclusion, STEC-HUS is indeed a severe systemic disease involving also neurological involvement. Specific treatments, unfortunately, remain an unmet need. Adult cases have a worse prognosis than children. The severity of adult cases is partly explained by the high frequency of underlying conditions, especially immunodeficiency. CNS involvement is more frequent, whereas diarrhea may be absent. So the typical image is not that easy to recognize in adults. This makes the early recognition on just clinical features of STEC-HUS not that easy in adults, and this encourages systematic testing for STECs in cases of TMA. STEC-HUS may be induced by extradigestive infections. Sporadic cases, at last, occur all over the year with a great diversity of serotypes, not only O157H7, and considering the epidemic potential as illustrated by the O104 epidemic, an active surveillance of all cases, including adult cases, seems warranted. Thank you very much for your attention, and thank you for all the clinicians, patients involved in this field. Particular thank you to Patricia Mariani Curjean and the National Reference Center for Escherichia coli, whose efficient laboratory is based in Robert Debré, and also to pediatricians with whom I also discuss quite often of this story. Thank you, and I will be happy to answer your questions if you have some.
Thank you very much, Dr. Dossier. So I really encourage the audience to raise questions because this is an unique occasion for directly ask to the expert questions, clarifications, comments. And also, it's also possible on the other way around, Dr. Dossier, that if you have any question to ask to the audience, like if they perform some practices or recommendation, it's also possible to have more interaction. And in the meanwhile, so I have received one question in private, so we'll write it publicly so you can read and answer.
Does TEC-HUS unveil pre-existing CAP abnormalities? Indeed, this is a good question. Our study in adults is not really good to answer this, but previous study in children performed by Véronique Prémaux-Baquier, I think I have it, the image here, was published 2 years ago, and now in children, in a cohort of 108 children, there is no clear association of pre-existing CAP abnormalities. There is still a little increase in pathogenic variants with minor allele frequency in cases, but very slight increase, and it's not the majority of cases. There are some cases that indeed, and also in adults, that reveal factor H mutations or anti-factor H antibody, but we didn't have any of such cases in our cohort. Is there any other question? Thank you
very much. So I can see there are very positive feedback that I also echo. So thank you for the excellent lecture. So I can see another question. Would you study
eculizumab further, or would it be beneficial in subpopulations of patients? Indeed, it's really, I'd say, the most important point for treatments. Eculizumab does not seem finally very efficient in mildly severe cases, I'd say. The real problem is in neurological severe cases. And to date, there is no data to recommend or in any way the use or not the use of eculizumab. It's compassionate use, I'd say, but there is no data supporting clearly this use. Some patients seem to answer rapidly to eculizumab, but some patients also get better despite very severe presentations without any specific treatment. So I can't say, I can't be sure of the efficacy of eculizumab. I'd say if there is a population in which there is a question, it's the population with CNS involvement. Maybe by selecting a population with a indication on blood of complement activation, like C5b9 soluble, I don't know. This could be interesting.
Thank you very much. So I have received one other question. Can you precise the role of immunodeficiency in the risk of developing STC-HUS in adults?
Yes, that's one of the most important and most striking point of our study, I'd say. Adults have been considered at higher risk when higher risk of STC-HUS over 60 years old, and it was said it's age. but in our study, age is not enough and it's not the heaviest weight for death. The heaviest are the underlying conditions, and particularly immunodeficiency. Immunodeficiency may be very important because for the susceptibility to staph infection. It was late in 2003, I think. It dates back to a long time ago. It was shown that the risk of staph infection decreases over the time while antibody anti-STX are appearing over the time. Maybe we lose this humoral protection with the time. It's one possibility. Does immune deficiency contribute also to more severe cases? Probably. And this is a really interesting point to understand exactly what is the predisposition to staph infection, because not everybody will suffer from staph infection despite staph contamination.
Thank you. So we have another question on COVID infection and vaccine. So may I also ask about COVID-19, sorry, I mixed languages, COVID-19 infection and vaccine. Do you see more TTP-HUS-like condition during the last 1.5 years?
So it's not exactly in the field of the today's webinar, which was on staph HUS, I'd say, but to insert this, TTP is really a complicated, TTP with a definitely low ADAMTS 13 and autoantibody, we do not see a frank increase of incidence in France during this COVID-19 epidemics. We have reports of chronologically linked onset of TTP flares after vaccination. Very, very rarely. We count them on two hands today. So we are investigating these cases to see whether there is more evidence for a definitive link between the vaccination and the TTP, but it's really rare, really.
Okay, so I can see no more questions arriving. So thank you, Dr. Dossier, for being here with us today. Also, thanks to the audience for the presence and their interaction. And see you in 1 week. Thank you very much.
Thank you very much. Goodbye, everybody. Good afternoon.
Bye-bye.